Ruth is 71. Active, sharp, plays Scrabble often with friends she's known for decades. Her knee had been bothering her for 2 years. Her surgeon was confident it was just a simple routine. But 3 weeks later, Ruth's daughter called me. Her mom was confused. She couldn't recognize faces. She struggled to find words. The knee was fine. Ruth wasn't. This happens more often than the medical system likes to admit. There are 4 things most surgeons never discuss before an older patient signs that consent form. My name is Dr. Liam Green, and this channel exists for one reason: to give you the information that should have been in that appointment, but wasn't. Today I'm walking you through 4 things every person over 60 deserves to know before any major surgery. Stay with me through all 4 because warning number 3 surprises people most. And number 4, most patients never get the chance to act on it even though the research is unambiguous. Before we get into the 4 things, one concept you need to understand. I call it the reserve gap. When you're young, your body carries enormous biological reserves. If something goes wrong, your heart, lungs, and brain each have capacity to absorb the impact and recover. After 60, those reserves shrink not because you're unwell, but because that's what aging does. A younger body weathers a complication in days. An older body faces the same complication with a much smaller margin. For younger patients, the question is, can you survive the operation? For patients over 60, the more important question is, can you survive the recovery? Most consultations never get there. Before we begin, drop a comment. Have you or someone close to you ever been surprised by what happened after surgery? I read every single one. Let's begin with warning. Number 1, nobody measured your frailty score. Arthur is 74, a retired architect, precise, proud of his independence. He went in for colorectal cancer surgery. His team checked his tumor, his heart, his lungs. All clear. What nobody measured was his frailty. Frailty is not the same as age. It's a specific medical measure of biological reserve, and it predicts surgical outcomes more accurately than almost anything else. A 2024 analysis in the Journal of the American College of Surgeons found that frailty and procedure risk were the strongest predictors of post-operative complications and death in elderly patients. A 2025 study confirmed that over 65s face complications 25 to 30% of the time with frailty as a key driver. And yet frailty screening takes less than 5 minutes, and most preoperative assessments don't include it. What to do instead? Ask your team directly. Has anyone assessed my frailty level? If they look uncertain, ask for a geriatrician referral. You have the right to that assessment. Let's go to warning number 2. The brain risk that nobody names. And this is what happened to Ruth. Her knee surgery went perfectly, but she came out of anesthesia as a different person. Not permanently, but for weeks that felt permanent to her family. What happened has a medical name: post-operative cognitive dysfunction, POCD. And it is far more common than most patients are told. A 2024 systematic review in Nursing Open found that POCD affects between 19 and 64% of older adults undergoing non-neurosurgery. That is not a rare side effect. A 2023 study also confirmed general anesthesia as a significant risk factor for cognitive impairment in elderly patients. Knowing this exists means you can plan for it, ask about regional anesthesia, arrange home support, tell your family what to watch for. None of that is possible when nobody tells you POCD exists. What to do instead? Ask your anesthetist, what is my risk of POCD, and is regional anesthesia an option? Any good anesthetist will take that seriously. If you're still with me, type 3 in the comments. It tells me you're getting real value, and it helps this reach more people who need it. This brings us to warning number 3. The preparation nobody offers you. This one surprises people most because it's not a risk. It's a solution that exists, works, and that most patients are never offered. Sylvia is 68, a retired librarian, scheduled for major abdominal surgery. Before she left my office, I asked, "Has anyone talked to you about prehabilitation?" She had never heard the word. Prehabilitation is structured exercise, nutrition, and psychological preparation in the weeks before surgery designed to build the reserves your body needs to survive not just the operation, but the recovery. A 2024 meta-analysis in clinical nutrition concluded that prehabilitation significantly reduces severe complications and shortens hospital stay in frail and high-risk patients. A separate 2024 review found it also reduces the risk of POCD. One program, 2 major risks reduced. Sylvia did 6 weeks. Her recovery took half the time her surgeon predicted. What to do instead? 6 weeks before surgery, ask, "Am I a candidate for prehabilitation?" If your hospital doesn't offer it, ask for a physiotherapy referral. Let's go ahead with warning number 4. The question nobody asks but should not a risk. A right. One question most patients never ask, but that changes everything. A 2024 review in the ANZ Journal of Surgery found that roughly 30% of all healthcare is low value or unnecessary. In spine surgery, procedures per capita in the United States run more than 5 times higher than in England and Scotland for identical conditions. A 2024 Medicare analysis found U.S. hospitals performed over 200,000 unnecessary back surgeries on older adults in 3 years. One low-value procedure every 8 minutes. Real patients. Real consent forms. No mention of another path. What to do instead? Ask your surgeon. If I don't have this operation, what does watchful waiting look like for someone my age? A good surgeon will answer honestly. If they seem uncomfortable, get a second opinion. You have time. Use it. I promised you something you can use. Write these down. Bring them to every surgical consultation. Question 1. Has anyone assessed my frailty level? Not my age, my frailty. It's the strongest predictor of surgical outcome and the one most often skipped. Question 2. What is my risk of POCD, and is regional anesthesia an option? Ask before you sign anything. Question 3. Am I a candidate for prehabilitation? 6 weeks of preparation can reduce complications and protect brain function. If it's not offered, ask for it. Question 4. What does the non-surgical path look like for someone my age? If nothing changes urgently in the next 6 months, you have time. Use it. Any good surgical team will welcome these. If they don't, that itself tells you something. Ruth recovered. It took 8 weeks, not 2. Frightening weeks for her and her family. Afterwards, she said, "I wish someone had told me what might happen, not to stop me, just so I wasn't ambushed by it." That's what this is about. Not fear, not avoiding surgery. It's about walking into one of the most significant moments of your later life with your eyes open, knowing the right questions, and knowing you are an active participant in what comes next. A surgical recommendation is the beginning of a conversation, not the end of one. Start with question 1. That's enough. I'm Dr. Liam Green. Thank you for your time today. Stay informed, and I'll see you in the next one.